Welcome to our pre-recorded general session entitled Sickle Cell Psychiatry, Embarking on a New Subspecialty. Our disclosures are here. Our objectives for this session are to recognize common psychiatric symptoms in people with sickle cell disease, identify stakeholders in a medical subspecialty clinic with a focus on sickle cell disease centers, and measure value added from integrated psychiatric care in comprehensive sickle cell disease care.
Hi, everyone. I'm Lauren Fields. I'm a current fellow. I have been working alongside the Adult Sickle Cell Disease Center at my institution for about 3 years now, kind of just getting to know the center, learning more about the patient population, and then really more recently have started to see some of their patients in an outpatient consultation model. The center is only for adults. It was started about 5 years ago and has over 200 patients. And what I really enjoy about working with this population is that there's a lot of opportunity for advocacy. It's a historically under-acknowledged, underrepresented, under-cared for population. And so there's a lot of work that still needs to be done, and there's a lot of room to really improve the quality of life of the patients that we work with.
Hi, all. My name is Bill Scheidler. I'm an assistant clinical professor at the University of North Carolina in Chapel Hill. I've been affiliated with our comprehensive sickle cell program here at UNC since I started as a faculty member about 6 years ago. Currently, I'm involved in about a clinic every other week or so, a half-day clinic, and then participate in a weekly team meeting on Tuesday mornings. So our center is, I think, a decently sized sickle cell center. We see over 300 adults in a given year with sickle cell. There's also a pediatrics program that sees over 250 children, but I'm not connected with that. That's more psychology driven. It's one where I think what I really love about this population is working in a collaborative team setting where I really get to work with folks who are deeply committed to the work. And I would say most often I am the first mental health provider many of our patients have interfaced with. And so I really appreciate the ability to serve as an ambassador towards mental health and really make a positive impact in the lives of our patients.
Hi, I'm Liz Prince. I'm an assistant professor at Hopkins, and I have been working in the Sickle Cell Center there since I was a trainee, so it's been about 10 years now. And I primarily work in our young adult clinic, helping our patients aged 22 to 30 as they're coming from the pediatric center into the adult center. The adult center as a whole is about 700 patients. But the young adults are a smaller proportion of that. Really what I enjoy about working in our sickle cell center is in part the teamwork, but also the teamwork sort of across settings. So I find it really interesting to get to take care of patients who are in the outpatient clinic, who are in the inpatient setting, or even doing telemedicine when they're at home, just seeing people in different environments going through different things and being able to offer a kind of consistency and a continuity to their care.
Hey everybody, I'm Pat Caroll. I'm at Hopkins. I work with Dr. Prince. What I write on the CV is that I'm the Director of Psychiatric Services for the Sickle Cell Center for Adults, but I completely made up that job and the title. But as Dr. Prince said, we have about 700 adults. We started out with around 200 to 300, and I came on board around 2007. I work a lot with complex chronic pain and sickle cell disease and have had somewhere between 20 and 50% of my effort supported through the division of hematology over the course of my career. And the thing I like the most is the patients. I do really like complexity and tackling difficult problems, and there's plenty of those in sickle cell disease. And I've really liked my team. We've got a bunch of really dedicated people who are very willing to work hard and very willing to work together for some people who don't get that kind of help very often. And so a very heartening place to work in a way.
All right. Well, now that you've met the players, surprise, this talk is baseball themed. So we're going to be moving our way around the bases. We're going to start on first base, talking about pathophysiology of sickle cell disease. Then we'll move on to talking about the stakeholders in sickle cell disease, the value added from sickle cell psychiatry at third base. And then finally, we'll bring it home with growth and expansion of sickle cell psychiatry.
Hi, everyone. I will be starting us off at first base, talking about sickle cell disease, including pathophysiology and complications. So this is a general outline of what I'll be talking about today, including pathophysiology of sickle cell disease, pain and sickle cell disease, neuropsychiatric symptoms, and then we'll touch on stigma at the end. So sickle cell disease is actually a group of syndromes that involve the autosomal recessive inheritance of a mutation in the beta globin gene, which results in the production of sickle hemoglobin rather than normal hemoglobin A, which is normal adult hemoglobin. Inheriting one mutated gene results in sickle cell trait, and two mutated genes results in sickle cell disease. The most common and typically most severe genotype of sickle cell disease is homozygous, with two copies of the beta globin S mutation. This is referred to as sickle cell anemia or SS disease. There are multiple other sickle cell disease genotypes, including sickle beta thalassemias and SC disease of varying severities. So sickle hemoglobin polymerizes into rods, resulting in sickle-shaped red blood cells, seen here in the graphic from the NIH National Heart, Lung, and Blood Institute. And this leads to hemolytic anemia and blockage of small blood vessels. All major organ systems in the body are affected by these processes. The second graphic here is from a 2017 NEJM review that demonstrates visually the wide-ranging impact of sickle cell disease on the body, from lung disease and heart disease to ischemic stroke and avascular necrosis to renal failure and priapism. The potential burden of medical complications of sickle cell disease can be tremendous. This is a geographical representation from the same 2017 NEJM article of the estimated number of newborns with sickle cell anemia in 2015. There's a high prevalence of sickle cell disease in particular areas of the world, including sub-Saharan Africa, India, and Western Asia. In medical school, we often hear about the malaria hypothesis, which was formed around 1950 and postulated that sickle cell trait, so again, this is the carrier state with only one mutation, is protective against malaria, which is now thought to have variable validity depending on the region of the world. The distribution of sickle cell disease has spread due to both population movement and the trading of enslaved peoples. Sickle cell disease affects millions of people around the world. A widely cited 2010 study estimated that at that time, there were potentially around 100,000 people with sickle cell disease in the United States. But there has yet to be a widely cited and reliable update to this estimate. Most people with sickle cell disease in the United States are Black and brown. So the life expectancy for patients with sickle cell disease has changed significantly in high-income countries. So interventions specific to the United States include the National Sickle Cell Anemia Control Act in 1972, which helped establish education, screening, testing, counseling, research, and treatment centers for sickle cell. However, life expectancy is still about 20 to 30 years shorter than the general population. Sickle cell disease was first described in Western medical literature in the very early 1900s. Hydroxyurea, which still remains the mainstay of treatment, was formally FDA approved almost 100 years later in 1998. Hydroxyurea works by increasing the proportion of fetal hemoglobin compared to sickle hemoglobin. It wasn't until 2017 that a second medication was approved, and currently there are only 4 disease-modifying medications approved for the treatment of sickle cell disease, one of which, crizanlizumab, has fallen out of favor. Blood transfusions are also used for management of sickle cell disease, but come with their own risks and complications. Currently available transformative therapies include hematopoietic stem cell transplant and newer gene editing therapies, which were approved in 2023. Likely the most common association that all of us have with sickle cell disease, and often why patients are presenting to the emergency department, is acute pain in the setting of vaso-occlusive episodes. What I personally didn't know until I started to learn more about this disease is that patients with sickle cell disease often have chronic pain as well. It's important to know that there are no objective measures of pain experienced in sickle cell disease. And particularly for chronic pain, there often isn't an identifiable cause. It's likely multifactorial and related to a complex interplay of various systems.
All right, next we'll talk about the stakeholders that are involved in comprehensive sickle cell care. And how do we integrate psychiatric care into these specialty clinics and into these teams? As a reminder, I'm Bill Scheidler, the University of North Carolina. I've been integrated as a psychiatric consultant into our comprehensive sickle cell program since August of 2019. Since that time, I've seen almost 200 patients, along with my colleague, Dr. Goodman. We've got our demographics here on some of the data we're trying to put together from our time in the clinic so far. One thing I will highlight is that in support of what Dr. Fields presented earlier, we see a lot of depression, we see a lot of anxiety in our clinic. And what's interesting is that for issues that we'll talk about in a little bit, over 80% have had no prior mental health treatment. That's both seeing a psychiatrist, a therapist, or a counselor of any type. So, as Dr. Fields mentioned, psychiatric comorbidities are common and understudied in patients with sickle cell disease, but we do know that those issues are impactful. They tend to amplify disease burden, increase cost to individuals and to the system, and negatively impact physical and psychosocial factors that you see listed there. Ones I want to highlight are the impact that it has on pain, frequency, and intensity, as well as higher utilization of our emergency rooms in our hospitals that are important to systems, and then impacting educational, occupational, and social achievement. Unfortunately, accessing traditional psychiatric care often doesn't work for our patients with sickle cell disease for a variety of different reasons. Some of that's more practical in that there's limited access to mental health treatment. There are socioeconomic challenges, and whether that's related to uninsurance or underinsurance for patients with sickle cell, and transportation difficulties, and whether or not that's even if folks have that transportation, being able to have that consistently to be able to attend to both of their hematologic visits as well as to psychiatric visits, and that can limit their engagement in mental health treatment. There's also an access issue on the other side of things, where oftentimes there's a lack of provider familiarity or comfort treating patients with sickle cell disease and the unique aspects of their care. There's also limited engagement. Stigma is ripe in mental health treatment. There's a lot of cultural beliefs and misconceptions that lead to decreased interest in engaging in mental health treatment. I think an added and unique clarifier for our patients with sickle cell disease is a reluctance to engage on the fear that, already a lot of their symptoms are being minimized as drug seeking or other issues. And is this going to lead to folks taking away my pain medication or the things that work for me? There's also competing demands. As we talked about earlier, there's socioeconomic stress and limited resources. Patients are forced to make really tough decisions, and the idea of adding another doctor or another appointment it sometimes can be too much. And as a result of the stigma above, mental health care often gets left by the wayside despite its importance. And the unpredictability of illness. So patients can go from feeling fine to feeling not fine very quickly. And as a result, in our clinic, we have a decent no-show rate that comes from folks either missing transportation or being in the hospital or just not feeling well enough to come to the clinic. And in a traditional model, those patients often don't last long or are not rescheduled for that reason. But while bringing patients to psychiatry doesn't always work, I think we can really effectively bring psychiatry to the patient and amplify the benefit that we have. We can improve access, we can improve engagement, we can reduce the barriers, both systemic and individual, and hopefully address some of the negative impacts that psychiatric illness have on hematologic outcomes and psychosocial outcomes for patients with sickle cell disease. But how do we do that? I think it's really helpful to start with understanding who are the various stakeholders that are involved in comprehensive sickle cell care. Some of the obvious are the patients. Maybe a less obvious piece of that is their family. Our patients with sickle cell are, they are sons and daughters. They are parents. They are spouses or partners. And how they function impacts, their community, who are often providing care or providing support to them. There's also their primary provider, which in this case are hematologists. We also have case management, which is a crucial part of any comprehensive sickle cell team. Some of the not so obvious, though, are our emergency departments and our emergency medicine colleagues who are often dealing with, in particular, a very small subset of high utilizers, and the impact that those relationships have on them and their colleagues, but also on patients with sickle cell disease. We have our hospitals and our hospitalists who treat folks while they're here in the hospital. UNC, we don't have a hematology service. They're consultants, so it's our hospitalist service or our teaching teams that are often admitting and managing these folks inpatient. We have our pharmacists, and we have community-based organizations. Here in North Carolina, we have state educators that are laymen, but have a pretty sophisticated understanding of sickle cell and provide support outside of the hospital healthcare setting. There's also the other individuals that kind of control the purse strings, and they influence resource allocation and service access. And so being aware of them and being able to find allies and support in this area is critical to the mission success. That's at a department, a division level, as well as a healthcare and hospitals level, and at the state, which often provides support for our patients, again, in a cost-saving perspective. And I think not only understanding who those stakeholders are, but also their perspectives are really helpful. So for our hematologists, I think they welcome us with open arms and are really appreciative for the help, because it allows them to focus on their hematologic care. So for a lot of our hematologists, this is something that I didn't appreciate before going into this line of work, is that they serve essentially as the primary care doctor for a vast majority of our patients. So not only are they ensuring that they get their hematologic or sickle cell care met, they're helping them manage their pain. They're also helping ensure that they get their diabetes taken care of and their high blood pressure. And so being able to offload something that causes providers a fair bit of distress and also is an area where they can be less comfortable with can be really effective. And at the same time, we can help empower them and improve their comfort with mental health care and reducing some of the moral distress that comes with this really hard job that we do. It also can highlight the importance not only for our providers, but I found that my greatest ally is our hematologists who say, you should meet with Dr. Scheidler. I think it'll be really helpful for you. We really think this will help. And so having that support in a non-judgmental perspective and having me an integrated part of the team really improves access for our patients. And again, for our patients, I'd say mixed bag, but a lot of that can be chalked up to some initial skepticism. I think many of them would be hard pressed to find a psychiatrist or bridge that into their everyday life. But when I'm in the clinic, sometimes it's okay, we'll sit down. And by the end, most folks are really highly engaged and really appreciate that ability to focus on their mental health. I think many of them appreciate that their sickle cell disease impacts their mental health and their mental health impacts their sickle cell disease. And so I think when approached in kind of a non-judgmental perspective on someone who's literate with sickle cell disease, I think there's a lot more buy-in from our patients. Case management really appreciates that assistance. A lot of those psychosocial issues fall to them without psychiatry. And so having that assistance allows them to do their job more effectively in case management, but may also be able to help empower them to be involved in, say, therapy or counseling, which happened in our clinic, where one of our LCSWs was able to pivot to a primary therapy role, which was at great benefit to our patients. In terms of our not so obvious stakeholders, oftentimes for our emergency medicine and hospitalist colleagues, we're working on reducing utilization, but also helping improve their literacy in managing sickle cell and the impact that that has. Um, and some of the trauma that comes from being involved in these challenging dynamics that are often informed by a very small subset of the population, but then kind of applied indiscriminately towards other patients. And it causes a kind of reinforcing pattern of kind of mistrust and challenging interactions. For our pharmacists, it's learning how to safely manage, all of these medications in patients with, complicated end organ damage from their sickle cell disease, and being able to integrate non-opioid management of pain into that more effectively. For our community-based organizations, they're hungry to learn, how they can better support their patients. And that's oftentimes, while they have a knowledge of sickle cell disease, they don't have a great knowledge of some of the psychosocial needs and psychiatric care needs of our patients. And so are really, really interested in learning more and how they can support their patients and get them connected. They love learning that there is a psychiatrist available through our clinic. And then for those that control the purse strings in the leadership perspective, oftentimes, certainly they care about reducing costs through reducing utilization, but also about collecting and improving PROs. And so it's really important, especially when times get tough, to be able to demonstrate value and have allies in that space, because that's often practically what you need. And then what about you as that psychiatrist considering going into this space? It's really an opportunity to develop a unique niche with a very rewarding patient population. With all the factors that Dr. Fields listed before, there is that potential for some financial support, which I would argue is really important and necessary to do this job well, given the unpredictability of our patients' lives and the value that we provide outside of direct patient care. And it really creates the prototypical CL experience. So how do you make it work? And how do you get started? I think it's finding a local champion that's often a hematologist to say, hey, how can I be helpful? And kind of going from there. It's understanding the players and the related financials. It's asking and being thoughtful about how you can demonstrate value and being able to show it and do that earlier. That's some of the work we're trying to do, is playing catch up in that area. It's seeking out financial opportunities. Again, I think it's hard to do this on strictly fee for service in our area. And so being able to have some backup, some support can allow you to really function well in this space. But that may be taking involved of state contracts or other nonprofit organizations. It's learning how to communicate and be flexible, knowing that things can change and that our colleagues really appreciate our help, but the needs are sometimes unpredictable. And really being an advocate both within psychiatry for sickle cell disease, but also within sickle cell disease for psychiatric needs. So I appreciate your attention, and here's my references. Thanks.
Great. Next up, I'm going to be talking about measuring the value of sickle cell psychiatry. I'm Liz Prince, and I'm going to move through a few ways that we've measured or demonstrated the value of our integrated psychiatric services in our sickle cell center. Starting out, I'll talk about my work in the young adult clinic. And so we were able to demonstrate the improvement in access to psychiatric care because of our integrated psychiatric services. So what we found was that in our population of young adults, 43% of them were referred for psychiatric care during just their first year of arriving in the adult sickle cell center. 24% of those young adults, so 56 of the people who were referred, went ahead and attended the appointments. And then for those patients, those young adults who did attend appointments, 91% of them had a mental health diagnosis, with the vast majority being mood disorders, specifically depression. And what we saw was that psychiatric appointment attendance was mostly just associated with how quickly you could get people scheduled. So if they were scheduled within 6 weeks of their referral, they were much likely to show up. So that value of having the integrated psychiatrist in the clinic really showed up in who we were able to see and take care of. Another way to demonstrate value in this space is looking at acute care utilization. So how often people are in the emergency room, in an infusion center, or even admitted to the hospital. One of the spaces where we've done some work on this is looking at the treatment of people with chronic pain. And so for a population of people who had chronic pain, were on high doses of chronic opioids, and even so were still coming frequently into the hospital. A treatment protocol was developed in which they were slowly tapered and then transitioned to the partial agonist buprenorphine. And what was observed after that was a pretty notable decrease in acute care utilization. So for the 6 months before being on buprenorphine, the mean number of acute care visits for these patients was about 10. And in the 6 months after switching to buprenorphine, it was a little bit less than 3. So that's, quite a bit less acute care utilization, which is, great for the patient. They're staying out of the hospital. They're not having as many needs to come in. But it's also great for the institution not to have this, this group of patients who are coming in frequently. One other way to demonstrate value is through looking at staff satisfaction. So what I'm going to share with you here is actually not specifically from sickle cell disease, but from our proactive psychiatry consult team at Johns Hopkins. And so this was a study in which we compared our proactive psychiatric consult team sort of before and after the implementation of the proactive model. And a few things that were observed was that the proactive model led to patients being seen more quickly in consultation, which makes sense. They're being screened and seen rather than waiting to have a consult be called. Also, there was a decrease in the length of stay for patients with the proactive model. But really what I wanted to highlight here is that nursing and physician satisfaction with psychiatric help increased significantly in a few different measures. And you can see in the diagrams here, red is bad and green is good. You can see that on the top line, before the proactive intervention, there was more red, and after the proactive intervention, there was more green. And the satisfaction of the staff and our colleagues, feeling supported, feeling like they have access to psychiatric care is a value that is brought to the table by integrated psychiatric services. Another area of value is clinician education. So having access to psychiatric experts increases the knowledge level of the clinicians taking care of patients. So one big way that we've been involved in education is actually through the ECHO telementoring model. So ECHO standing for Extension of Community Health Outcomes. And this is a model where online people are able to meet for telementoring sessions and really take that expertise and spread it beyond the walls of just a single clinic or a single institution to an entire region. And during these sickle cell echo sessions, what happens is de-identified case discussions, where folks are able to bring in a difficult patient or issue and discuss that with a group of experts. And those experts include psychiatrists, Dr. Caroll and myself, who are able to sort of bring that psychiatric perspective to understanding how behavior or mental health condition or attitudes of the team may be influencing some of the challenges in the case. There's also a short didactic in each echo session, and these are a wide range of topics related to sickle cell disease, but certainly sometimes these didactics are on depression or on other psychiatric topics that help to educate clinicians. And the nice thing about echo models is that it does also allow a collection of data. Participants can do surveys or demonstrate that they've gained certain skills. I highlighted here the support echo, which is specifically for sickle cell disease advanced practice providers. And I hope to have some data to share about specifically some of the learning about psychiatry topics in that group in the future. These are just a few of the ways of demonstrating value. Sharing just a few more here. Collecting billing and revenue data. It's unlikely that an integrated psychiatric clinic is going to create a profit, but certainly even being able to demonstrate that you're offsetting costs is helpful. Being able to demonstrate cost savings. I mentioned before things like a reduction in length and stay, and depending on your healthcare model and payer system, that could look a little bit different. Patient engagement and retention in care. So being able to measure who shows up to appointments, who continues to stay in routine outpatient care, being able to demonstrate that psychiatric services can help improve that is a great way of showing your value. And then clinician wellness and staff retention are also things that, can be measured and can be demonstrated to sort of, again, highlight the importance of this interdisciplinary approach that includes integrated psychiatric services.
And so I'm going to first talk about kind of, as it says here, how I sang for my supper, how I developed into the role that I've currently got, and how that's been sort of funded and supported and stable. And then from there, maybe talk about different ways that those of us who want to get involved could get involved using either that sort of model or different models. So for a little bit of context, I've been at the Sickle Cell Center for Adults at Hopkins since about 2007. I first began, I guess you could call it volunteering, by seeing some fairly complicated patients when I first started working there. And then as we opened our sickle cell infusion center, there was actually a line item budget for the hospital side to the university to fund a quote unquote drug counselor who was believed to be an important part of the clinical model at the time. The folks who were developing the center and the infusion center thought that maybe it would be more useful to have me than to have that planned drug counselor. Our model is, I don't think entirely unique, but it was certainly, I think, very unusual at the time. And part of what was unique about it, I think, was that we all, like all the disciplines that were really involved in the center, all had a seat at the table. So our hematologist ran the place, but we also had advanced practice providers, our social worker, myself, several other disciplines. And among other things, we all met together every single week and talked about all our patients together. And this created, I think, a pretty useful dynamic where each individual discipline, including psychiatry, could influence the clinical methods and culture. And in my own case, just by nature of the patients that I wound up seeing, which I'm going to talk about in a minute, I think sort of psychiatric thought processes and thoughts around behavior change really kind of integrated itself into the way we treated pain, in addition to doing things that you would recognize as more general psychiatry. And so we developed this kind of system where there's the psychiatrist's job and the social worker's job and the APP's job and the hematologist's job. And it's a bit more that there's the job. And so, for example, my APPs and hematologists are plenty good at screening people for depression, beginning the antidepressant before I even, get on the scene. And likewise, they know what I do. They know what's realistic for me to be able to promise and what isn't. And so we wind up with a lot better dialogue about how to manage particular problems rather than kind of having someone referred to you when you can't really help very much, but you might be able to give advice to the person who can. So anyway, so this arrangement has allowed me to continue having sort of stable support for mostly clinical, but also some what you might call administrative effort. And then over the years, I've also cultivated a few research interests and helped people out on various grants. So, and the way this works is kind of as I described before, the infusion center or our acute care center and the center itself does a lot of good for the hospital administrative side, some of which I think what we've done in psychiatry has helped. And then the hospital side funnels revenue to the university and the division of hematology, which then supports some part of my salary. Part of, I think, how this has been sustained is that we've developed this approach to managing complex chronic pain in sickle cell disease that I think is pretty psychiatrically informed. So acute pain in sickle cell disease is the thing we know the most about how to manage. When someone has an episode of acute pain and they do come into the hospital, and basically you want to get them from the door to the first dose of analgesia very, very quickly, preferably within half an hour, but 1 hour tends to be more realistic for emergency departments. And if you do that, then people tend to have better pain outcomes and are more likely not to get hospitalized. On the other hand, there are individual people with sickle cell disease, a very small group of people who are in the emergency department or the hospital many, many, many more times than a typical person with sickle cell disease. And these are the folks who contribute a lot of cost, a lot of readmissions, and also, the standard issue way of treating people in acute care settings kind of stops making sense when you have someone you're seeing the 53rd time that year, and it's September. And so, these are a lot of the folks that I first started seeing, and in the process of working with them, I learned a few things about them and also learned some ways of treating them that were both better for them, better for us, and actually wound up saving money. One correlate of all this is this subpopulation of folks who tend to account for pretty much all of the readmissions. So this is a study I did fairly early on that got published later, where we looked at hospital readmissions at Hopkins and compared the patients with readmissions with a control group of people who did not have readmissions. And what we found was, first of all, the readmissions were really concentrated in a very small group of people. So at the time, we probably had like 400 to 500 patients. And we looked at it, about 7 patients accounted for over half of our readmissions, and 3 patients accounted for a third. And these folks who were more often readmitted or had readmissions, period, had a higher prevalence of just about every bad thing, every complication of sickle cell disease, every comorbidity, and psychiatric conditions. And it was remarkably consistent. It was almost double the prevalence pretty much wherever you looked. So very often around this group of patients, this idea of addiction just sort of swirls. And the question becomes, can you figure out who's addicted and who isn't, and then do something for them that's different because, you figured out who's got a substance use disorder. But I think, our experience has turned out that this is a massive oversimplification. And in fact, the trouble is complexity. Like, these are folks who tend to have really bad sickle cell disease, a lot of psychiatric comorbidities, and are kind of stuck in a forced choice between being in the emergency department and seeing a hematologist like, once every 6 weeks or 6 months or whatever, which just doesn't work. And so we developed a different way of thinking about this that integrates this idea of a really sick group of people who need intensive outpatient care and also have really complex chronic pain in addition to a lot of psychiatric comorbidities. And these were the people I really started working with a lot from the beginning. Made all kinds of mistakes, and then 10-ish years later, kind of maybe started figuring out something to do that was better. And in the process, I think we really reduced a lot of iatrogenic harm to this subpopulation, as well as reduced hospital use that probably didn't need to happen, and improved the health of the patients overall, and also made the administrators happy, which is nice when you can do all those things at once, if unusual. This is a case in point of someone I got involved with who was a very frequently hospitalized, who came into the emergency department pretty much every week or two. That's the red lines there, and then was admitted every time he came in, really. Treated as usual with intravenous morphine, stayed in the hospital for a bit of time, left, seldom actually made any outpatient appointments, and then the cycle would just keep going and on and on and on. And so this was basically someone who had chronic sickle cell disease pain, who was being treated with chronic opioid therapy, essentially, but it was being done in this kind of disorganized way where it was all hospital and ED and never really outpatient with a long-term strategy. So I contributed some to the care of this patient. Some of the things that we did were, first of all, we stopped reflexively admitting to the hospital for uncomplicated crises if you didn't have acute chest and things like that, in addition to really ramping up the disease modifying therapy as much as we could. And then that's when the hospitalizations dropped off, as you see there. And then later on, we rearranged things so that when he was in the emergency department, he wasn't treated with things you can't use at home. So we switched from IV to oral. At the same time, figured out how much opioid he actually was tolerant to and made it so that when he saw his hematologist outpatient every single week at the same time, if at all possible, he simply got that dose in terms of sort of chronic opioid therapy by one team who had a longitudinal, appreciation of what he was doing. And this basic approach is one of the ways that we've taken on this problem. And as you can see here, even in really complicated and difficult cases, it can work. At the end of that, in the last several years, when we have people for whom chronic opioid therapy has failed or who are frequently in the hospital a lot, we started using buprenorphine as a safer alternative to chronic opioid therapy, which I have some background in addictions, and I was sort of versed in the use of buprenorphine. And so I think that helped us transition to start using this a bit more. And in the process of doing that, it turns out that, when we do all the things I just said for the patient I was just talking about, you also can wind up, when people do transition to buprenorphine, with lower hospital use. So this is a pre-post study we did of people that transitioned to buprenorphine. You see the acute care use really dropped off. One thing I should point out here is that while that group on the right who switched over to buprenorphine looks like a significant decrease, and it sure was, that is not a low utilizing group of people with sickle cell disease. These people still are very ill, very complex, all have chronic pain, often have other psychiatric comorbidities and complications of the sickle cell disease. So it's not a miracle pill by any stretch of the imagination, but when used with the strategy we've developed, it seems to help. So this sort of thing is what I've kind of made my living doing, dealing with sort of complex chronic pain in people with sickle cell disease, as well as general psychiatry, and managing the depression and anxiety disorders that are common in this population you've already heard about. And so this is kind of how I've managed to keep a seat at the table. Now, different sickle cell centers are very, very different, however. So at Hopkins, we have one place. Historically, for most of the time the place developed, we had one hematologist who ran the place. And then we had the rest of the team who helped and supported our director in running the center. There are other systems where you have multiple different hospitals in the same system. Sometimes they talk to each other well, sometimes they don't. Sometimes you have multiple sickle cell disease experts, and so different people have different patients. And sometimes you have multiple different hospitals that are completely different creatures, but might have individual centers. And so all of that could probably influence things in a lot of different ways. So I think if you're looking to get into this business, one of the things you want to do is find out the structure of the centers and the places that you're at, and ask what the role of psychiatry is currently, if there is one, and what the people who are running the place want the role of psychiatry to be. So in our case, Liz and mine, we have a seat at the big table as a rule, and we have a lot of input into the direction of lots of parts of clinical strategy in the center. In other places, what might be envisioned or desired is more the idea of diagnosticians It might be, well, we need someone to send a patient that we know has X thing to for pharmacotherapy or psychotherapy and so on. And so you want to know if what's being envisioned is what? Are you being asked to be a consultant to provide treatment to people who have already been diagnosed, or are you being asked to help to build the whole thing? And then, that all probably fits into what the nature of your center is. So, for example, if you have a relatively small center with a skeleton crew, the idea that you're going to have room to be, a director or something of that sort might be not where they can go, and you might want to figure out a way to help out alongside the place. On the other hand, there are places that have tremendous numbers of patients, if you happen to be in like Florida or Texas or in Atlanta. And in fact, they might need 4 or 5 of us, even if they don't have us. And so, knowing the lay of the land and the individual place that you want to get involved can help a whole lot. And then we have this problem that there's just not enough of us. And so another question is, how can we actually kind of spread ourselves in a way that can be helpful? There is the integrated model that Dr. Prince and I have at Hopkins, but I think there's other different ways that psychiatrists have fit into some of the centers that I've seen. There is the consultation model where patients are sent here for an individual consultation. You make recommendations, send them back. Certainly for the complicated patients that I look after, I have not found this to help a lot because I usually wind up telling people what I think the first move should be, which almost never works, which then leads to I'm not there for the second, third, fourth, and fifth moves. And so I often feel like I'm letting people down when I do these one-time consultations. But I think there are certain situations, maybe sort of conventional affective disorders and things like that, that it might help. It'll help you build a relationship and help people out who need the help. There's the classic referral model, which is, you have the center and the sickle cell clinicians who then maybe know one of us and then send patients to us for diagnosis and management in our own outpatient clinic, whatever that works on. Generally speaking, sickle cell disease is a relatively rare condition. The payer mix ain't great, and they're a pretty complicated group of people. And so they are not, I think, appealing to the powers that be in most outpatient psychiatric clinics that are already overburdened and find it a lot easier to get paid for general psychiatric patients. So I think this can work with a dedicated champion who really wants to look after people with sickle cell disease. I also think you're going to have some fights if you want to build things that way. Another model that I've seen in several centers, and usually ones that are big enough, is that they will employ and integrate a psychotherapist, usually an LCSW, sometimes when lucky and with the resources, clinical psychologist. Now, mainly these models are usually referral for co-localized therapy. And how much diagnostic assessment and management of complex patients can be handled can depend. It depends on the experience level, training, and so on of the individual person and the expectations of the primary center. And for this model, typically, you're going to need some kind of outside supervision or referrals for step-ups in care. Really complicated patients with severe psychiatric illnesses, patients with complicated psychopharmacology, and so on. And a thing I've been thinking about a lot as a way to spread those of us who are in this world a little thinner is, could we implement a collaborative care model using telemedicine, telepsychiatry, for example? There's no real implementation of this in the sickle cell disease world. And I think, the great opportunity is it can distribute an expert from one place to multiple different places. And if you can have a, behavioral health care manager integrated into the individual clinics, and then as the psychiatrist interface with those folks, maintain a panel and then use measurement-based care according to the collaborative care model, I think there's a lot of room to do good. but I think that it might be niche at this point. But these, I think, are the ways that mostly we can help out our colleagues in hematology and look after this very complex and population that really needs our help.
Now, we'll discuss some frequently asked questions about sickle cell psychiatry. What is your approach to the treatment of depression in a patient with sickle cell disease? What do we think?
Yeah, I'm happy to start us off. I think I'm a lot earlier on in my kind of clinical experience with patients with sickle cell disease, but I think what I've run into the most often thus far is the question of, should I start with duloxetine? Should duloxetine be the first medication that I prescribe for depression, in the hopes that it may also help with pain? And I would say that, so far I've run into patients who are on SSRIs, who are taking other medications for depression and have found a lot of utility from them. And so the knee jerk doesn't always have to be to just start with duloxetine. I think you can kind of use a similar process you would use for any patient, thinking about what are the side effects I want to avoid or optimize, what is this patient most likely to be willing to take on a regular basis? And what will be kind of best for them in the long run overall. And the answer doesn't always have to be duloxetine.
I will say one factor that sometimes plays a role, because I would 100% agree with Lauren that you don't need to be thinking about this differently than someone else, say, without sickle cell disease. And you don't need to jump over the SSRIs, which may be sufficient to really effectively manage folks' symptoms. I will say that for many patients who are maybe a little on the fence about whether a mental health medication could be helpful or not, the potential for some improvement in their pain, which for many of our patients is a significant and primary symptom that they experience on a near daily basis, can be a good selling point to have them invested in that. But I think it's also better to understand, what's everything else going on in their care? Like, are there any other end organ issues as a result of their sickle cell or other issues? Are there, is there adherence issues, financial issues? They're going to be limiting their ability to kind of continue to take this medicine on a regular basis, with all the pros and cons that come with each of our individual agents.
SNRIs can work for depression, so can for pain, and so can tricyclics, but the effect sizes tend to be kind of modest. Number needed to treat the benefits probably like five-ish, maybe. But depression you can get in remission if you keep trying, and I think that's probably a bigger effect. So I tend to think that unless someone has an absolutely miraculous response for their pain, if it's not working for the depression, you still follow the rules. You keep trying different things, and it doesn't have to be an SNRI.
Yeah, and I think when I am thinking about especially these serotonergic medicines, I do just consider what other medications they're taking, the potential for serotonin syndrome in combination with other with opioids. How do you respond to a consult request for, quote, assessment of psychiatric contributions to pain?
So this is one I get a lot because I kind of made a bit of a stock in trade in particularly complex chronic pain and sickle cell disease. And as you might already guess, some of these variations on the question sort of start out with the idea that we have a hypothesis about what's the right question to be asking you. And sometimes our colleagues need a little help to find the right question that we can give an answer to that will actually do them some good. But when I'm asked these kinds of questions, it usually means we think something is going wrong here, and we think maybe you can help. And so my first, pass at trying to find an answer to the question is to figure out if there is in fact something weird or going wrong, because treatment for pain with people with sickle cell disease is pretty fraught, and not everybody sees it all the time. And so, for example, you have a person with sickle cell disease who comes in the hospital, and it's the first time they've been in the hospital for 2 years, and they've been given 1 milligram of hydromorphone, and they say 3 is what works for me. And you look back in the chart, and in fact, the last time they were in the hospital 5 years ago, 3 is exactly what worked for them. this can get some people very worried. And sometimes my job is to say, no, don't worry, just do it. And to help people know what's typical and what's atypical. When it is atypical, when you have someone who's, a rare patient who's like spent 25% of their time in the hospital this past year, or is on a walloping dose of opioids for chronic pain, and their pain's still 8 out of 10 every day. A lot of the time, the first thing I actually wind up doing is not talking about a mood disorder and things like that, even though for that subset of patients, the presence of a mood disorder is almost a foregone conclusion, frankly. But it's more dotting the I's and crossing the T's on actual sickle cell management and pain treatment. So, is this person on adequate disease modifying therapy first and foremost? Are they having crises they shouldn't be having? And then if a lot of times this is about opioids. And so rather than trying to read someone's mind about how they're coping or what are the reasons they're using the opioids, I tend to flip things around and think about, is the way we're using opioids making sense? So, if you got someone is taking a really high dose of opioids and has pain of 8 out of 10 every day, that would be what I would usually think of as a thing that is not working. And so you don't necessarily have to come up with some complicated reason why it's not working, to just say it doesn't work and make an alternate plan. Similar thing with the occasional patient who has really frequent acute care use or really prolonged hospitalization. Sometimes a prolonged hospitalization is just because someone's really, really sick, and that's that. Multi-system organ failure and acute chest don't go away overnight. At the same time, I have run across people who have had hospitalizations for months with pain that hasn't budged, no matter how much opioid you give. And so there are times where you got to rethink whether what you're treating should be thought of as chronic pain, as treatment refractory versus acute pain, and how you manage that. So a lot of the times what I wind up doing is telling people, I think we need to reformulate the way we're treating the pain because it's not working. And oh, by the way, yeah, I really think we should screen this person for depression and treat them for it, but that's a 6-week project at the very least. And we have a few other things we need to kind of get together before that. So it's a little bit more reframing towards what's actually weird versus what just seems weird because we're not familiar with it. And then how to do the pain management by the book. And then we get into the psychiatry. I think sometimes we get stuck in this kind of affirming the consequent fallacy. We must treat the patient's pain X way, unless fill in the blank, it's not real, it's drug-seeking behavior, it's blah, 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 blah. And so when people get the feeling that something's going wrong about the pain treatment, they look for that blah, 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 blah to find a reason to change the way we're treating the pain. And that usually, I think, involves looking at what's wrong with the patient rather than what's wrong with what we're doing, which goes very bad very quick. So I usually encourage people not to try to figure out this real pain thing. When I'm feeling provocative, I'll say, well, what's the opposite of this real pain you're talking about? And that makes people think a little bit. But I get away from the real pain thing. And the other thing, particularly when it comes to chronic pain, this idea about an opioid requirement, I'm not sure it really holds water. What we know about chronic opioid therapy for chronic pain seems to be that, the number needed to treat the benefits probably like 3-ish. You expect maybe an 1/8 of a point reduction in pain when you start it. And after the first 6 to 8 weeks, the idea that, well, all we got to do is go up. If the pain goes up and it'll get better, doesn't really seem to hold water either. So I think there probably isn't exactly such a thing as an opioid requirement for chronic pain over the long run. And it's more about, is what we're doing working and is it worth the risk? And if you can reframe it that way and not make it about like what's wrong with the patient, what are they up to, what's going on in their head, which we can't answer, I think it decompresses a lot of that and helps us be a little more rational and not, frankly, mistreat people.
I think to that point that I think that's where the role of a psychiatrist in a comprehensive sickle cell team can be so powerful, is to be able to check some of these assumptions or to question very gently some of these assumptions, which I think hematologists in many ways are in a really tough spot,
Hmm.
because they are not pain doctors. And oftentimes pain anesthesia wants nothing to do with our patients. And so here are internal medicine, hematology oncologists that are now pain doctors, which is not their preferred method of treatment here. And on the flip side, for our patients, I think it's a good reminder that for many years, life expectancy from sickle cell was very poor and very limited. And these are now adults who were told as children, you're not going to live very long. And here is the medication that will provide some relief from your suffering. And there, because of a lot of complicated factors, including low life expectancy and maybe an underappreciation for the relative dangers of these medicines, a lot of our patients just got on more and more and more and more opioids. And now that's where I've seen an issue as well of these patients who have been on high doses of opioids for a long period of time. And now we're telling them, actually, you don't need that. And we're going to take away this medicine that for decades or for many years was the one thing that provided some bit of relief from them. You know, physical, psychiatric, whatever the source, it was providing some relief from them. And I think it's important to think about what I think, most common experience, especially for high utilizers in the healthcare system are, that I think it often bleeds into the experience of just about every patient with sickle cell, is someone looking over the side of the curtain in the emergency room. Are they really in pain? They're texting. They're telling me 10 out of 10. But the number, if you go through in your patient's chart and look at what's documented, reporting 10 out of 10 appears comfortable. Even little phrases like that make it so, like, turn it into such an adversarial interaction. And so patients are understandably skeptical, protective, and uncertain when you bring in any discussion of let's lower that opioid requirement. And again, I think it's the thought for many of them, you're going to take away the one thing that works for me, and I'm never going to be able to get it back.
Yeah.
I will say one thing on this question that does sometimes help is our patients are really aware of what are triggers for their sickle cell crises. And what I have found is, so what role does pain or what role does stress play in your pain experience? And I think by and large, just about every patient I've talked to, that feels like a very approachable way, like, oh yeah, when I'm stressed, my pain gets worse. And that's a good starting point for building what is something we can do to complement your pain regimen. I think many of them feel threatened by this idea of it's all in your head, you're all faking it, you're addicted to these medicines.
It's easy, I think, for the patients to get the idea that this is yet more evidence that I am being disbelieved and my pain is believed to not be real or imaginary or not physical or whatever. No, no, no. The pain's real, and by the way, if you got a depression and the pain, it actually can be worse. We're not going to stop treating you. We're going to add stuff. We're going to try to do more to help rather than discount you and show you off to somebody else. And framing the question that way before they even get to us, I think can help a lot.
When do you prescribe stimulants for patients with sickle cell disease?
I'm happy to jump on this grenade first. I will say the easy answer is it depends. And I think it depends on a lot of different factors. And as we were talking with a group earlier, I kind of made the comment that it's kind of like building the plane while you're flying it. But this is something that I think has come up, a surprising amount in my practice. And then taking a look and conferring with the experts here on the call, there's not a great resource. And so sometimes it is kind of figuring that out as you go. And that's why I think first and foremost is really leaning on your team and being able to come up with some standard approach with dealing with these issues and acknowledging, I think, to yourself even, that I don't need to have the answer right now and today. This is something that I can say, I'm going to look into and to talk about it with your team. Sometimes it depends on what type of model you have in your clinic, whether or not you are doing primary or direct patient care. Are you doing more of a consultation model? And if you're doing more of a consultation model, what's the comfort of those who are doing the prescribing in prescribing a stimulant. I think one thing that we've done is really try to provide a standard approach on the types of patients where we're thinking about stimulants. Oftentimes we're looking, did this patient have a childhood history of ADHD? Were they managed previously on a stimulant? If so, how did they do? In terms of kind of where they are now, I'm also wondering, what is their MME there? Like how much opioids are they on, and are we going to be fighting against a really high level of opioids that could also be impacting someone's attention? We've also been very lucky in having kind of some neuropsych and neurocog resources. And so some of those patients will send, especially those are in our transitions clinic who are looking to go to school or are in school. And being able to approach that both as a better understanding of what is contributing to their executive function difficulties that they're noticing, but also providing accommodations that they can use academically. In terms of agents, I think it works very similar to how you'd start an adult without sickle cell disease, but it is one oftentimes where I'm being maybe a little bit more cautious when I'm starting these medications, making sure that I'm doing an appropriate screen for end organ illness in these patients. And we've got a great cardiologist that every now and then gets a question from me, hey, does this person seem like a reasonable person to start a stimulant on? And so again, really relying on a team approach. And then the last thing I'll say is that sometimes it gets messy because of some of either overt strokes that patients have had or silent infarcts. There is some level of cognitive impairment that can be somewhat sneaky in our patients, and oftentimes executive function is implicated. And so it'll be interesting to see, if we get a little more time under our belt, is it helpful for those sorts of impairments, with or without kind of the ADHD phenotype that's there. The last thing I'll say is I think, again, to that standard approach is thinking about some sort of screening tool. And that may depend on what your institution has access to. I use the ARDS as it's something that is very easy to use. It's free online, and it gives me at least some marker to jump in. But it's been an opportunity for collaboration amongst my other CL colleagues, and what are they doing? And I don't think there's a great answer anywhere in this for this particular situation. The one other thing would be just thinking about other potential causes and other opportunities to optimize, say, mood or anxiety disorders. There's also a high predominance of obstructive sleep apnea in our patient population, and so making sure that that's been looked at, that there's been a sleep study. So it's more than just, hey, I'm having these systems. Let's start the stimulant. It's often a really thoughtful exploration with the team about what are all the potential causes that could be contributing to this, including an ADHD type diagnosis.
On that note, I mean, I personally probably think about prescribing stimulants about 8 to 10 times more often than I actually do prescribe stimulants, because I can never quite convince myself, what evidence applies to the cognitive problems of sickle cell disease from, the ADHD literature. But one of the things that happens for me a lot is I'll have a patient come to me having, looked up on the internet, why am I having trouble completing things or something along those lines. And then ADHD comes into the thought process, and then a patient will come to me and say, I think I finally figured it out. um, and like, it's also not unusual for particularly my patient population, who are older, usually maybe their 30s or 40s, to not really have known or appreciated the cognitive problems that come with sickle cell disease as such. So, trouble in working memory, processing speed, executive function, all that seems to come with sickle cell disease in and of itself. Um, to say nothing of the people who've had the silent cerebral infarcts and the vasculopathy. And so sometimes it also kind of opens up a conversation about that, actually the differential is a little broader than this. And it may be that we don't get quite the same results out of stimulants for you because this isn't as clean cut as someone who has no other causes going on. And that can sort of help the patient appreciate, oh, so it's not as simple as, the internet says. And I think that also can help a lot in, the shared decision-making process when you're talking with the patient about what you're doing.
I think related to what Pat was just saying, I just met with a patient who was in their 30s, was diagnosed with sickle cell when they were 6 months old, and was saying that there are things that they're still learning about their disease process. And I think I, at least for myself, tend to assume that patients are coming in with this extensive knowledge of all the potential complications of sickle cell disease and how it could impact their functioning and their cognition. But as Pat was saying, there is a lot of room to still educate patients about the things that they might face, things that they might have experienced thus far.
Well, this is our favorite question that hopefully you're asking yourself now. My institution doesn't have a sickle cell psychiatry. How do I get involved? So, I think the first thing we would recommend is just get to know the people at your institution who are working in the sickle cell space. Show up to meetings, see how they do business. I guarantee they'll be excited to see you. There is a National Alliance for Sickle Cell Centers, so you can check that out, see if there's one at your institution already, or in your region, and maybe get connected with them. And then reach out to us. Here are our email addresses. We're happy to help in any way, if folks are interested in this space of sickle cell psychiatry. All right. Thank you.